Good evening, everyone. We're delighted to spend our Monday evenings with you. We're here with the lovely Helen, who's going to look after all of the housekeeping and everything technical for us. This meeting is recorded. And I'm also joined by the amazing Dr. Helena O'Flynn, who will take care of all of our medical questions for us. My name is Dani, and I'm your hostess, together with the other lovely ladies for you this evening. We wanted to put together a very short, we thought it was going to be an hour, but if you have a bit more time, I think we might run over. Very informative webinar for you. We don't know where you are in your journeys, but we're going to just take you on a little exploration. And afterwards, we're going to have time for questions and answers. Menopause and womb cancer, what's the deal? Because menopause post-cancer is a totally different ballgame. And we want to explore this with you together. Now I need to see, now it's not going to my next slide, but hang on, it will do. There we go. The Peaches Womb Cancer Trust, who is hosting us tonight, is improving the lives of those with and at risk of womb cancer. I'm sure you have all found their website, peachestrust.org, and they've also got a fab Instagram page and so many other resources. And we're going to send you an email tomorrow with more links, should you want to look a little bit further. The reason why we're here today is we have all been affected by cancer. We've had a cancer diagnosis. This has resulted in the onset of menopause. This could be temporary or permanent. You might have physical and or mental symptoms. Many of you tell us that you've not had enough support and information. It can be a really lonely place and confusing to be in this situation. And it's often very hard to know what to do next. I was going to start with some fun questions, and I wanted to ask you lots of questions, but I think we're running a little bit late. So I'm just going to get on with it, if that's okay, Helena. Is that okay? Yeah. For some reason, it's not liking me just progress through my slides. Now, just need to do this. Many of the women we speak to say and tell us a similar story. Many say, I wasn't offered any help with my menopausal symptoms. I don't know what I can ask for. I was never given enough information if HRT is an option for me or if it's not. And what alternatives are there? I'm at my wit's ends. I just want to feel like me, the old me again. How does anyone else manage cold turkey menopause? I just feel really lost. I'm worried about my bone health. I'm fed up of everyone talking about how great HRT is, and I don't think I can have it. And many people say, oh gosh, I wish Davina McCall would stop talking about how amazing HRT is. And the majority of women we speak to say they've had no support at all. And tonight's workshop really is just there to change that a little bit. Like, we know there is only so much we can do within the hour that we've got, but we're hoping that this will be a starting point to change some of these common complaints. I need to apologize why my computer isn't letting me whiz through. The aim of the talk, as I said before, we want it to be really informative, jam-packed with sound advice, evidence-based facts. We want to give you tools that you can put into practice to have a greater understanding, and to also share some coping mechanisms with you, so that you can then figure out what could your next step be. And this is going to be very, very different for each one of us. And I always feel, because we're in a community of like-minded people, it just makes it a little bit more bearable, a little bit better, and we know that we're not alone. Why this is so important? Because 92% of people that we speak to feel really isolated in their experiences. Many say they feel like they should not complain, as they should be so grateful that they've survived. 84% of people say that they've never spoken to another person in menopause post-cancer. And 88% of women say they've had no help at all, or very little help, in managing their menopausal symptoms. I'm so delighted that the amazing Dr. Helena O'Flynn from the Peaches Womb Cancer Trust is here today to answer all of those questions for you that are so difficult usually to sort of get the answers. So what we have done is we've put together all of the questions we had before the webinar, and we're answering them in the slides. And should there be some mopping up to do, then I'm sure Helena will be happy to do so afterwards. Helena is a GP working in Manchester following the completion of an academic clinical fellowship training program and a master's in public health. And her massive interest in the early detection of gynecological cancers in primary care and women's health is just fabulous. And that's why she's just so wonderful to talk to, because not only has she got all of the academic experience, but her practical experience and her special interest just make her so perfect to talk to. She graduated from medical school at the University of Manchester and was then awarded an NIHR doctoral research fellowship in 2018. She's undertaking a PhD at the University of Manchester, investigating methods of early detection of endometrial cancer, as well as awareness of symptoms of endometrial cancer. And you will all know that managing menopause after cancer is not just like everyone is the same and we're all thrown in this big pot and we all have the same treatment options. You will often hear women who've had breast cancer talk about what is or isn't available to them. And it's very particular when you've been diagnosed with womb cancer. And so having healthcare professionals like Dr. O'Flynn is just absolutely brilliant with that level of expertise. I'm Dani Binnington. I founded a platform called Healthy Whole Me many years ago now. I've got 3 daughters. I just said to Helena earlier, one of my daughters is 12, the others, 2 of them are 12, one is 14. I'm a cancer survivor myself, just like all of you here tonight. I then became a menopause guide. I'm a yoga teacher and a family wellbeing expert. But what I'm most passionate about is to help women transform their own well-being in whichever way that is possible to you and in whichever way you want to do that. So I run a private Facebook group because I'm a real believer in joining the right community. I'm a contributor to the Balanced Menopause app, and I founded the Empowered Menopause program, which I also run for many charities and privately as well. And I've hosted the Menopause and Cancer podcast because I always felt that there is a big menopause conversation going on out there, which is brilliant. And I always felt excluded from this greater menopause conversation. And so all I want to do is open the conversation for all of us so that we feel heard, so that we can share with people who've been through similar journeys. And quite frankly, that gets me out of bed every morning. A long time ago, I thought that not a single week went by where I wasn't outraged at the lack of information and the lack of support there is for women in general. And then I became even more outraged at the lack of support and the lack of information there is for women who are struggling with their menopausal symptoms after cancer. But of course, all of this is changing. And thank you to the Peaches Womb Cancer Trust for making that change happen. I'm delighted to have, the opportunity so that we can all talk about this tonight. Just a little bit about my healing. I had this real urge to become as active as possible in my own recovery and share this with my community. As you can see here, my little girlies were very little when I was diagnosed with breast cancer in my early 30s. And at the age of 39, I chose to remove my ovaries, which plunged me into an early onset menopause. And it was really preparing for that early onset surgical menopause that I realized how little information there was out there and how much we can share, because information is there. We just need to look in the right places. But really, we want to talk about you today, and we want to find ways or help you find ways of how you can move from where you are right now. And we know that's going to be totally different for all of us, and to move you into maybe feeling a little bit more empowered, perhaps through information, through knowledge, through evidence-based facts, through debunking some myths, and how you can make that next step, even all the way to how to navigate the medical system. So bear in mind that you're all hopefully going to gain something different from tonight's get together. One thing we are really passionate in sharing with you is there is absolutely nothing wrong with you in how you're feeling. If you're thinking navigating your menopause after a womb cancer diagnosis is challenging. We totally get it. And so many of you feel the same. There's nothing wrong with you. It doesn't mean that you're not recovering quickly enough. It doesn't mean that you've been lazy and not researched all the heck out of all the symptoms or the solutions that are there. It just means it is a really sticky situation to be in with sparse information, and there's nothing wrong with you. And much of us as a whole person changes after a cancer diagnosis. And so much more even changes when you're then being thrown into menopause as well. It's really hard knowing what's what. It can be really confusing to know what your next step can be. But please know you're not struggling because you're weak or because you haven't done your research. It can be a really tough journey to navigate. Just going to see if I can click that away, because maybe that's a bit better for all of you to see my screen. We wanted to go through the menopause symptom checker, and that's not to reiterate for all of you that already know what your symptoms are. You might think, oh my gosh, I've got all the symptoms under the sun, or you might actually not be quite sure. Are your symptoms because of your menopause? Are they because of a different sort of late effect of maybe a treatment, a surgery? But we thought it'd be quite fun for you to put the symptoms you think you have that are associated with your menopause into the chat box, and then I run through them, the ones we have on our slides. And we'll all take a big breath together, because what I don't want you to do is start to worry about other people's symptoms. Because one thing that we know about the experience of menopause, with or without a cancer diagnosis, is it will affect us so very, very differently. Some people will get some symptoms to varying degrees for a period of time and then they ease off. And for other people, their symptoms might persist for a much, much longer time. And so one thing we really want to urge you to do is never compare yourself to anyone else. There will always be someone else who's much worse off than you, and there'll always be someone else who's much better off than you with fewer symptoms. One thing that is really important to us is for you to think, what's important to you? Which symptoms do you really want to get addressed? And then to go and find the help, because there will be someone to help you and there will be something that you can do. And I think that's the best way to look at this. So we're going to start with mood swings, anxiety, panic attacks, to add here, irritability or low mood, and sometimes persisting low mood, the feeling that you've lost your mojo. A lack of motivation, being tearful, loss of joy, reduced confidence was definitely something that really crept in for me when I didn't notice it for a long time. And at one point I realized that I was overthinking every time when I've been out with friends, and I thought, oh, is she going to be upset with me, or is he going to think I meant it in a different way? I was overthinking everything. My confidence had sort of lost me in believing that I was okay socializing. I had to sort of mull everything over, and that was a really slow sort of symptom that crept in for me. And it took a long time for me to realize. I kept thinking people won't want to sit next to me at dinner parties because I'm so boring. And yeah, it might not be a massive symptom, but it actually did really affect me in the long run. Brain fog, like many of you put down, fatigue, that real fatigue, poor memory, poor concentration. Difficulty sleeping, that could be difficulty to fall asleep, or it could be waking up in the middle of the night and then not being able to fall back asleep. Loss of libido, or absolutely no desire, no sex drive, painful sex, night sweats or hot flushes, but also, like someone put down, freezing cold suddenly, this temperature going up and down. Headaches and migraines, heart palpitations, tinnitus, feeling dizzy. Changes to periods, if you still have periods, vaginal symptoms, and they come with such a big array that they can really stop you in your tracks. It can be really painful to wipe yourself when you've been on the toilet. It can be painful sitting on a bike, sitting on a chair. Reoccurring urinary tract infections, or other urinary symptoms, the feeling that you constantly have to go to the toilet, for example, or that you, when you put the key in the lock, that you can't hold it anymore. Dry and itchy skin, dry eyes, ears, nails, thinning hair, and oral health changes are all part of, sadly, the menopausal symptoms after a cancer diagnosis. And then we've also got that really stubborn weight gain, restless legs in the middle of the night, joint or muscle aches or pain, increased allergies, and digestive issues. And we know that's loads, and we don't want you to worry about any of the ones other people have put in the chat box that might not be relevant to you. We just wanted to really go through the list so that you know how much there is that we really have to deal with, so that we can be a little bit more self-compassionate as well towards ourselves. We know that some of you might now be thinking, oh my gosh, I've got nearly all of these symptoms to one degree or another. Or you might say, I nearly have more of those than I don't, but I always put them down to other things. And you might also think, I have some symptoms, but I still don't know if it's menopause, post-cancer, or to do with the pandemic even. There's such a jet lag of emotions for so many of us. Sometimes it's really, really difficult what's what. But we also want to say to you, don't worry about it, because we don't always need to address everything in one go. Once we've got a little bit of a plan, and once we've worked out what is it that you want to address first, then we can move towards finding the steps and the solutions for help. And if any one of you have a phone next to you, and you can go into your notes or a scrappy piece of paper or a notepad, then maybe you could put down the 3 top symptoms that bother you the most at the moment for yourself. And you don't have to share them with anyone. You don't have to put them down. Maybe just take a moment to reflect and think, actually, out of everything that is going on for me and has maybe been going on for the last 2 months, or say since November, what is bothering me the most? And we'll just give you a minute for now. Before we move on, I also want to say to you, don't make those symptoms, don't assess them, don't judge them. Don't think, are heart palpitations bad enough for me to go and seek my GP? Is it bad enough to get help? Don't judge them. Just put down for now what it is that bothers you, because some amazing doctors, when I speak to them, they always say, Dani, if it bothers you, it should bother your doctor. And, you know, some women wake up 3 times in the middle of the night and they fall back asleep. They've become so used to it, it's okay for them. But other women wake once a night and it's really, really, really impacting how they're living their next day and how much energy they have. And so that doesn't mean you shouldn't seek help. If it bothers you, you should seek help. So don't think, is it bad enough to get help? The reason I'm saying this is, if you put things down on your sticky note or on your piece of paper, it's probably bothersome enough for you and go and do something about it. And hopefully we can find a step tonight that you can make a first step towards your little action plan. We believe that this action plan is never a this or that approach. And even when you listen to people like Davina McCall and they all go, oh my gosh, HRT is the only thing and the best thing, I dare to say it's not quite as straightforward. It's not a this or that approach. We are now a different person. We have been through a cancer diagnosis and we're in menopause, and our whole body probably needs tweaking here and there for us to feel better again. Your action plan needs to be as individual as you are, and often it needs to be a multifaceted approach. There is no right or wrong. And one thing I'm really, really passionate about in this menopause conversation is to make sure that you are supported. There are people out there who have very strong opinions about how we should or shouldn't do things in menopause, but you are you. And we want to support you in finding out how you can carve out a life that really works for you. And you know, if someone takes antidepressants and the next person thinks there is absolutely no way I'd go on antidepressants, I hope that as a community, we can be as open-hearted and as open-minded to support each of us with whatever we think is the right thing for us to do. And remember, we can change our mind. Nothing is forever. If we decide to do one thing and try one thing this year, you can change your mind. Go vegan this year, go and eat all the meat you want next year. You do you. You don't have anyone or anything to answer to anyone. And I think it's most important that we keep this menopause conversation supportive and judgment-free, because I feel there is enough judgment out there, especially in the menopause space. One thing I think is wrong, and I won't be quiet about it, and that is when women don't have the information, or there's a lack of support from their medical team. And I don't want to blame anyone, because there isn't anyone to blame, but at the moment there just isn't a direct sort of path woven into our survivorship that gives menopause the attention it needs. And until then, we just have to carve out our own path. But we should all have the access to get better help. So many of the symptoms you've put down, there is so many things you can do about those. And I'm excited for you, when we speak to Helena in a second, for you to take your notepad out and start to scribble what you can do about it all. And this is where I'd love to bring Helena in, if that's possible.
Yeah, cool.
So Helena, as a GP who runs a very busy schedule, we have just seen how many problems and physical and emotional problems with anxiety women have. How do we navigate the medical system? So we don't know anything about all of the lovely ladies that are here with us tonight. Some might have been in menopause for a long time, others might have just started their journey. Talk us through GP, menopause specialist, and what do we do?
Absolutely. The first thing I'd say is it's really important for anyone who's experiencing menopausal symptoms really to be able to seek and obtain appropriate care effectively. And as you know, in the UK, our first port of call is usually our GP. And as we've discussed, there's obviously a wide range of menopausal symptoms experienced. So we mentioned the symptom checkers earlier. It's really quite useful to both as patients and also as doctors, if you can have a look at those symptom checkers and try to have a think about, as we've mentioned, what is worrying you or what is bothering you or what is affecting your quality of life, so that you're really able to go to that GP appointment knowing exactly what it is that you want to discuss and what you want to get out of that appointment. I would also say one of the biggest things that I would advocate is, if you feel comfortable doing so, it might be really beneficial to try and book with a GP at your practice who has an interest in women's health or an interest in menopause. We are growing in number now, because there are a lot more women who are seeking help with menopausal symptoms. So, you know, there are a lot more of us who have that interest in menopause. The other thing I would say is, you know, think about any decisions that you take about if you want to seek any treatment for your menopausal symptoms really should be personalised. And what I mean by that is that everyone sat here tonight will have different risks in terms of their other medical problems, what type of womb cancer they've had. And also, you know, personal preferences. As we mentioned, there are some treatments that people are willing to try and some that others that may not want to embark on. All the things to mention is that a GP may need to seek advice about what they can offer you and what is safe for you to take. And that can be for many reasons, as I've just mentioned, but often they may want to talk about your womb cancer diagnosis with your oncology or your gynecology specialist. And if they think that your symptoms or that your history is a bit too complex for them to manage, they may also want to refer you to a menopause specialist. And one thing I would like to just say here is we know that the wait for menopause clinics are very different around different parts of the country. So it's worth having that conversation with your GP about that. What is the wait time to be seen in a menopause clinic within your area? I know in the Manchester area, which is where I'm based, we now have a service called Advice and Guidance. And what that means basically is that we can write to specialists and ask them some advice around a patient, and that they will be able to write back to us without having that long wait for you to be seen in clinic. We know obviously seeing a specialist face to face or on a one-to-one basis is probably preferable to patients, but whilst we're waiting and have those long waits in place, it really is worth, you know, seeking help through those kind of options, really. And I know you've put the link there, Dani, really helpfully to a accredited menopause specialist within the UK. So that's the BMS link that you can see on the right hand of the screen.
One thing to say about the long waiting times is please don't be disheartened. If you ask your GP to refer you to a menopause specialist and maybe it comes back with over a year of a wait, it can be so disheartening, but don't be. Because for those of you who've had surgery and your ovaries might have been removed or radiotherapy, you are probably going to be in menopause for the rest of your life. So even if that menopause appointment comes in a year's time, you can make really good use of that specialist then, and you will probably need ongoing care anyway. So I'd always say, be as optimistic as you can with the wait, make it as positive as you can. Like Helena said, ask your GP to write to them and use that time. Don't be disheartened because the waiting times are long, but in the meantime, think there's lots of other things I'm going to do. This isn't going to be, I'm going to put all my eggs in one basket. Is that fair enough to say?
Yeah, and I think there's a comment there about in the chat about surgical menopause being a priority. And we recognise that you know, this is, you know, an area in which women are, as I know you mentioned earlier on, Dani, they're experiencing menopause in a very rapid fashion, so symptoms can be much more severe, and we recognise that, and we do endeavour to help support women as best we can with that. And I know we were going to talk about the range of things now that hopefully we can discuss about ways in which we can help with menopausal symptoms.
Yeah. When Helen and I were preparing for tonight's talk, we really wanted to make sure that all of you know that we don't have a hierarchy of how you can start addressing your symptoms. There are buckets, we call them our sort of toolbox, our buckets of information. We have medical hormonal treatments, medical non-hormonal treatments, complementary therapies, a change in mindset, a change in lifestyle, and avoiding triggers. And if we do a little bit of each and maybe just open a bucket or put our hands in and take something out of all the different buckets, we have a really good chance that we can address our menopausal symptoms from varying degrees. And we're just going to go through those now. But if you just take those in for a moment and think, is there anything I'm drawn to? I just think I need medication and that would be fine. Or you might have been thinking for a while, I really wanted to eat a little bit differently, but I don't know where to start. Or you might be thinking, yeah, complementary therapies, that's something I'm curious about. I wonder what that could do for me. Because as a patient, it's really important to also trust your gut again. We have been so prodded and sort of manipulated in a way, and our control has been almost taken away from us for a period of time. It's important to now think, what is it that I want to do? And I'm going to trust my gut again. I'm going to trust that gut feeling again, that I also know what's right for myself. Helena, let's talk about medical non-hormonal treatments and which ones can you prescribe as a GP, and which
absolutely.
ones do you have to refer on to?
So as Dani just mentioned, there's lots of different ways in which we can possibly help with menopausal symptoms. So one of the options that are open to your GP or your medical professional is prescribable. So that means they have to be given with a prescription, non-hormonal treatments. And there are several different ones of these. So the main one that you may have heard of before is different types of antidepressants that we can use. So the top line is regard to an antidepressant we call SSRIs, which are also called selective serotonin reuptake inhibitors. And essentially these are your standard first-line antidepressant that we also use for low mood and anxiety within the UK. And we know that as well as affecting mood, there is some evidence that they can affect vasomotor symptoms or hot flushes with varying degrees between 20 to 50%, the latest studies think. However, we should bear in mind that they do sometimes have side effects in some women. They're overall well tolerated, but they can lead to nausea, dizziness, and importantly, as a class of drugs, they can lead to worsening sexual dysfunction. However, as I said, some women really find these beneficial for those hot flushes. It's also worth bearing in mind that there are a few of these medications that can't be taken with a drug called tamoxifen. Tamoxifen is a drug that's used for both the treatment and prevention of breast cancer, and it's a hormonal drug, and it's just worth noticing that. The other medication that we also use a slightly different type of antidepressant called venlafaxine. This has some good evidence, but it tends to be slightly less well tolerated than the other class of antidepressants, and it can cause some dizziness. Gabapentin and pregabalin, these are drugs that we use for epilepsy, and we also use them for nerve pain quite routinely in primary care. Again, however, there is some evidence that they may reduce pain, anxiety, and hot flush symptoms that are caused by the menopause. They can lead to some side effects, including dry mouth and dizziness. And clonidine, as we've mentioned there, is the only actual licensed alternative for hot flushes. And however, they can act on the blood pressure, so they may interact with some other antihypertensive or blood pressure medications. And side effects include sleep disturbance, which is often reported by some women. And you've listed a few more there. There is oxybutynin, which we use to act on the muscle layer of the bladder, but can also affect hot flushes. And osfenithine, which is a drug called an SERM, or a selective estrogen receptor modulator, and this can also help with vaginal dryness and irritation. We're going to speak in the next slide a little bit more about hormonal therapies, and I'll just go on to that slide to talk a bit more about other non-hormonal methods to treat vaginal symptoms as well.
Before we go on, I just wanted to probably say what I know many of you at home are going to be thinking, because I have been speaking to hundreds and hundreds of women who are in menopause after cancer. And at this point, many of you at home might think, oh my gosh, I've had so many drugs and surgery and things done to me. I don't want any more drugs. You might be thinking, I don't want to go on antidepressants because I'm not depressed, but your doctors won't prescribe you antidepressants because they think you're depressed. Some of these antidepressants that Helena was mentioning, it's the fact that they treat menopausal symptoms is a byproduct of the medication. And most times you'll be given much, much lower doses than a person who might be clinically depressed and going on the same antidepressants. And the other thing I want to add is that in general, in the menopause conversation, you would have heard in newspapers, in even TV programs, GPs prescribe antidepressants wrongly for the treatment of menopause. HRT is the first line treatment. Well, that's correct, but you are different. And once we've been dealt with menopause after a cancer diagnosis, we have different treatment options that are available to us. So don't think your GP doesn't know what he or she is doing, or that they want to fob you off and think you're just depressed taking antidepressants. These are actually studied antidepressants for women after a cancer diagnosis. And because I know it's so hard to think, oh, I've had so many drugs, I don't want this. But if you're really struggling, it can be interesting for you to just have a little feeling and think why you might be for or against something, so that you're not dismissing something, just to really make sure that you keep all the doors open. That's the only thing I wanted to add here.
And there's just a question there about antidepressants and how long we use them for menopausal symptoms. And there's no clear guidance on that. But with antidepressants, we usually we review a patient when we first start them, so within the first few weeks, just to make sure that they're not having any side effects that they can't tolerate or that we need to change the dose for. And then once someone is stable on them, I would usually review them every 3 to 6 months. And then if they were really helping you, then they would probably just review them as part of your annual medication review, if I'm honest with you, unless you were having problems with them or wanted to have a very strong feeling to come off them yourself. It's worth just mentioning, if you are on antidepressants, that we never stop them suddenly. So we always reduce them in a gradual way. And that includes sometimes when changing from one antidepressant to another. I don't want to get too complicated with it, but often, again, that needs the guidance of your GP on how to do that in a safe manner. And your GP will guide you with that. And we normally would, if we were to come off an antidepressant, we'd do that over several weeks and reduce you down very slowly, because you can get some bothersome and quite unpleasant symptoms if you stop them very suddenly yourself. So that's why we do that. So I hope that answers your question there that you put in the chat.
And Helena, medication like oxybutynin for bladder problems and hot flushes, it works really well, doesn't it? For people who have maybe incontinence or that urge of always going to the loo or not feeling that you can empty your bladder properly, it can be really helpful.
Yeah, it can act on the smooth muscle of the bladder, to do that. Absolutely, it's licensed for that use.
Right, okay, so our medical hormonal treatments, we know there is much talk and much confusion over, and I'm sure many of you have perhaps had a conversation with your healthcare professionals about whether it's appropriate for you. And so what Helen and I thought would do is just give you the evidence and explain to you what do we know to date and what do we not know.
Absolutely. So the first thing I'd like to say is that with HRT, or hormone replacement therapy, essentially what it is replacing the estrogen that we lose through going through the menopause. And essentially by replacing that estrogen, we will therefore improve our symptoms of the menopause. And primarily the one that we see a big improvement on is the vasomotor symptoms or hot flushes. And there's two types of HRT. So the first type, which I'm going to talk about, is local vaginal estrogen. And as we mentioned, the lack of estrogen that we happens after we've gone through the menopause causes a lot of skin changes around the vagina, the vulva, which is the area around the vagina, and the urethra, which is the tube in which urine is passed through. And essentially the skin becomes very thin and dry and irritated and less lubricated. This can result really in it becoming quite painful and irritated and even itchy. And we call this vaginal atrophy, which is essentially the medical word for thinning of the skin and dryness of the skin. And what we know that local vaginal estrogen does, when it's given as a cream or a gel or a ring or a pessary, is it acts on the vaginal tissue to improve the quality of the skin by normalising the acidity, making it thicker and much more lubricated. Worth noting is that much lower doses of hormone can be used locally to improve vaginal symptoms compared to systemic HRT, which I'll discuss in a moment. So this minimises the amount that's absorbed by the whole body and affects other organs such as the breast tissue. So we know that if you used a whole year of estrogen in the vagina, that would be the equivalent of taking one HRT tablet. So that's kind of the equivalent of what is absorbed by the body. It's worth noticing that I think we'll talk about this a bit more in more detail, Dani, won't we, later, but if you didn't want to use a hormone to treat vaginal irritation or atrophy, there are some non-hormonal methods in which to do this. So there are vaginal moisturisers and lubricants, and we often recommend now using a water-based lubricant or moisturiser, and these can be prescribed by your GP as well. Current evidence suggests that for women who've been affected by womb cancer, that there is no increase in the level of recurrence for women that are using vaginal estrogen. So in summary, we feel that these are regarded as safe for women who've had womb cancer. Systemic HRT, this is HRT that is absorbed by the whole body, and therefore acts upon all the symptoms of the menopause and not just the local skin. And systemic HRT consists of replacing estrogen. And in women who have a womb, we would also give them a hormone called progesterone to protect that lining of the womb from becoming undergoing changes and the development of womb cancer. However, most women here tonight I know have been affected by womb cancer, and they will have undergone removal of their womb through hysterectomy and ovaries. So most women here would only require estrogen-only HRT. What are the benefits of HRT? So the benefits include the relief of the symptoms we've discussed in a lot of detail. And we also know that whilst taking HRT, our bone density is protected. And we also know that our bone density is protected for a few years after stopping HRT as well. We also think that in women who start HRT before the age of 60 or within 10 years of menopause may also have some slight protection of cardiovascular disease, but the evidence is limited on that. I just want to mention here, because I don't know what the age range of everyone sat here is, but for women in our younger age group, so who've gone through a surgical menopause, particularly before the age of 40, which may be some of you here, HRT also does have some additional benefits as well, because we know that undergoing an early or premature menopause can affect your long-term risks of cardiovascular health and osteoporosis on the bones. So what are the risks of HRT? So if we take HRT by a tablet or an oral preparation, we know that there's an increased risk of stroke, of clots in the legs or lungs, and also known as a DVT or a pulmonary embolism, heart disease, and also stroke. And we know that those risks are higher in women over 60 taking oral or tablet form HRT. However, we often now, first line, don't give HRT through a tablet. We tend to give it through the skin, either by a patch or a gel or a spray preparation. And we call this transdermal preparations of HRT. And for those reasons I mentioned about the risk, we know that this is a better preparation for most women to take. It's also worth noting that it doesn't, it has also several other advantages. Doesn't interact with as many other medications when we give it through the skin. If there's women who have digestive or gastrointestinal conditions, we know that it doesn't rely on absorption by the gut. There's also less issues in women who have liver problems as well. And with these sprays and gels, we can start women on very low doses and we can titrate them up if needed. So you can go up and down on the dose as required for your symptoms. In terms of side effects of taking estrogen HRT, some women may report bloating or breast tenderness and nausea. But again, if that were to occur, we can talk to you about different options and different methods of giving you that estrogen. So we know that some women will start, say, on a gel, but don't particularly get on with it for one reason or other. We may change them to a patch. One thing we've heard a lot about with regards to HRT is the risk of breast cancer. And I know a lot of people worry about the risk of breast cancer. So for women taking estrogen-only HRT, so that's a type of HRT we give to women who has had hysterectomy, we think there is no or little increased risk of breast cancer compared to women who may need HRT with the two types of hormones in. So that's women who have a womb. We know that there's around 4 extra cases per 1,000 of breast cancer. What is really worth noting at this point, if I'm honest with you, is that there are lots of other factors that increase our risk of breast cancer. So it's not just HRT. These include things like family history. So some women have a really strong family history of breast cancer, smoking, alcohol use, and weight. So we know that being overweight or obese is a real major risk factor for developing breast cancer, especially as we get older. This is why we really need a personalised approach to HRT, because every individual's risk will differ by taking HRT. If you were to start HRT, usually after a review with your GP, you would be seen again after 3 months, again, to check you're not having any side effects and to check that it's working for you. And then once women are stable in HRT, we usually review them on an annual basis. Also worth noting that there is no guidance of an exact age that HRT has to be stopped. And that if you do stop it, we would usually advise doing that again over several weeks to months, and that gradual reduction so that you don't get a plunge back into menopausal symptoms, essentially. And I know what we're all quite really interested in here today is what is the evidence regarding the safety of HRT and the recurrence of womb cancer. So the British Menopause Society produced a document in 2020, which is called the BMS Statement. And what they looked at is all the available evidence regarding the studies that have been conducted about women with womb cancer that have then used HRT. And what they've concluded is that the use of HRT following treatment of womb cancer has primarily shown no increased risk of recurrence. However, this is for women who've had early stage disease, and I'll explain to you about that, why that is. All the studies that have looked at the use of HRT have primarily looked at women who've had what we call early stage, so stage 1 or 2 cancers. There's not an abundance of data for women who've suffered more advanced stage of womb cancer. And we also know that some of these studies have looked a bit more at the younger age group of women that develop womb cancer. So as I mentioned, the conclusion is the evidence up to date doesn't show massively increased risk of recurrence, but there is some limitations to that data that we must bear in mind when we're discussing our options. And this is really where most GPs, for a woman that's had womb cancer, that goes to speak to their GP about going on HRT, some of them will want to speak to your specialist because they may not have all the information about the type of cancer, the grade or the stage of cancer that you've had, and they may want some more detail about whether it's safe for you. And this is really what we mean when we talk about shared decision making. We need to have that conversation about what are the risks of me starting this treatment, what are the benefits, and let's talk to my whole cancer team, who has looked after me with my womb cancer and who's got the expertise to discuss what are the pros and cons of each treatment. And it's also worth noting, I think I just forgot to mention that endometrial or womb sarcomas, which is a much rarer type of womb cancer, we often say that HRT cannot be given with these cancers because they're very highly estrogen dependent. So that is rare, but it's worth mentioning because some women here may have had a sarcoma. And I'm just having a look here. There's a few questions come through, Dani, if we can. I don't know if we can.
Yeah, before we go to the questions,
yeah.
Helena, I just wanted to say to you, it's really difficult as a patient, and I know that from my own personal experience, to sort of navigate that experts have different opinions. Like, I know so many women whose surgeon might have said, yeah, it's fine for you to go on HRT, but someone else in their medical team said, no, I wouldn't go on HRT. Like, why is it that we can have different opinions? And then how do we navigate that? It's so difficult to know what to do when that happens. What would you suggest?
Yeah, and I think that's really difficult. And I guess the bottom line is, as GPs, we are generalists, and we would always seek that expert opinion. But I know that can be confusing for patients. And the other thing is that, like I say, everyone has a different experience. So they'll have different risk factors. They have a different type of womb cancer or a different stage of womb cancer. I think it is just really having that open mind, having that conversation as a wider team about what is right for an individual patient, really. And that's the need, essentially, to advocate for yourself in this environment. As clinicians or as doctors, we all practice what we call evidence-based medicine. And essentially what that means is that we look at all the studies that have been done regarding a topic to see, is it safe for us to do something? And we base that on evidence. And sometimes the answer to that is yes, sometimes the answer to that is a clear no, and sometimes the answer to that is somewhere in between, in a bit of a grey area. And unfortunately, with a lot of women who have had a cancer diagnosis, sometimes the data is just not there in abundance. So we have to say what we think, what we feel is safe from the evidence that's available, but bear in mind there's always some limitations to that. And hopefully that's what I kind of explained in the last slide, really, that, we think at the minute, based on the evidence that we have, that in most women who've had early stage womb cancer, that by giving HRT, that we don't think it's increasing the risk of recurrence to a significant level. But as I mentioned, there's limitations for women who have stage 3 disease, for instance. We just don't have those studies there. And as I mentioned, some of the studies that have been done are in a little bit of a younger age group, because obviously we were more likely to give HRT in the past to women who were younger, undergoing a surgical menopause. So that's where that data is.
Yeah. Would you like to have a look at the questions? I'm conscious
I think I've answered a few of them, to be fair. So hopefully I have. So 39, very worried about bone heart health. I'll just mention that. I'm not sure if we've put that in later, but it is worth mentioning that all women who've had either a surgical or have gone through the menopause, we do make sure that you get some adequate weight bearing exercise, which I know Dani's going to speak about in a little while, but also vitamin D and calcium. So make sure we have that in the diet. Again, I think we're going to talk about that. But we do recommend around, I think, 1,000 milligrams of calcium and 1,000 units of vitamin D in your diet, which we can give you some links to. But essentially, in the UK now, there is some evidence suggesting that during the winter, we should all be taking a vitamin D supplement as well, because obviously we don't get a lot of sunshine, unfortunately, in the UK. So that's a really important factor for bone health, which I know we're going to have a chat through in a bit more detail.
And one lady just said her consultant is really against her taking any form of HRT. And what we want to say to you today is, we know that there are different opinions within all of the medical teams out there, and that exists for women in breast cancer, for women with womb cancer. I know the conversation is very similar. It's a lot of the times based that we don't have lots of data, and there aren't like studies with hundreds and thousands of women. Sometimes the studies are very small, and not every surgeon and not every oncologist is totally keen in exploring all of these treatments of the menopause either, because it's not actually their expertise either. So if your consultant has said no, but you want to explore it further, go and explore it further. Ask the difficult questions. Show me the data. What's the latest evidence? Go on the British Menopause Society. You do the digging and continue the conversation with that consultant. That's all we can do at the moment, isn't it, Helena, I guess?
Yeah, absolutely. Absolutely. And the answer to that last question there, best talking to your GP or gynecologist, well, either is fine. But if I'm honest with you, the ongoing prescription for any sort of therapy that you wanted, whether that was non-hormonal vaginal moisturizers, whether it was HRT, the vaginal or systemic through an antidepressant, that would usually be done through a GP. So if I'm honest, what I would probably do is go and speak to your GP, and they can always liaise with your gynecologist. They can write to them and they can speak to them to get any specific advice that they need. So hopefully that answers your question there.
And before we even address vaginal HRT or whether it's a pessary, it's really important to have a good vaginal routine in terms of how you wash your face. You start to wash your vagina. And there's so much I had to learn when I got into my 40s even, that no one really taught me about. Many of the products you can buy in Boots are full of rubbish, and we shouldn't even ever buy them. And there's a brilliant brand called Yes Yes, and GPs can prescribe it. And so it's really sort of looking at what is it that I can do and how can I come up with a really good vaginal routine, from moisturizers to washes and all of that, before I even perhaps have to go down the vaginal estrogen route.
Absolutely, that's it. And it's worth noting that we do advise, sorry if I've blurred out with that, we do advise, you know, we don't really advise using any soap-based products on the vagina at all, because it affects the pH, and it can also lead to increased risk of infections such as bacterial vaginosis. So we just really recommend, you know, as I say, washing with simple water if you're washing at all. And yeah, essentially that's, you know, good vaginal health is simple, really.
From now onwards.
Yeah. So that's my advice on that. And then, you know, also if you're going to use, as I mentioned before, if you're going to use a lubricant or a moisturizer, we do think the water-based ones, which you mentioned, yes, is one of the products that is water-based. We do think they are much better now.
Yeah, from now onwards, if any of you are out there having a lovely facial routine and you put moisturizer on your face, think about your vulva and vagina as well, because if you suffer from dry vagina, itchiness, irritations, painful sex, it can be really helpful to incorporate that into your beauty regime. But we're going to whiz through some of the other slides. When we talk about complementary therapies, we want you to really explore what you think resonates with you. We often get asked about medical herbs like black cohosh, rhodolia, St. John's wort, adaptogens, red clover, sage. And often women say, are there contraindications to some of the medications I'm already on? If you want to go and buy something, say, in your local health food store, it's great to look at the THR registration mark. It's just a little logo that's on most herbal preparations that have gone through some screening process. So you know that the quality you're going to get, the consistency and the strength of the product is what it actually says on the tin. But furthermore, I think it might be really helpful for you to explore whether you can go and seek the conversation with the herbal medicalist. Because if we believe in the power of plants, and, you know, plant medicine has been supplied to us for hundreds and thousands of years, and they are strong and they do work, otherwise there wouldn't be contraindications, a herbal medicalist will do all the thinking and legwork for you, and you can come up with a plan. And we're just going to leave it there because we don't want you to dismiss herbal medication, but we want you to be really safe with them and also really know why and what you want them for. So you do need a little bit of a plan rather than spending 50 quid in Holland and Barrett's and you don't really know what all of those herbs do for you. Women always ask about CBD, cannabidiol for pain, anxiety, inflammation, and sleep. And there is so much anecdotal evidence to support this. You can get gummies, you can get oils, different strengths. We just haven't got the evidence yet for effectiveness of big clinical trials. But that doesn't mean they might not work for you. Another thing from speaking to many women is The women who take them consistently over a longer period of time found them to be more helpful than the women who take a few drops on a Monday, forget on a Tuesday, and bring it out when they're really anxious again. Many menopause specialists talk about a bee pollen. The product is called Fermal. And you can also look at cognitive behavior therapy, or CBTI, cognitive behavior therapy for insomnia. Now, CBT is not going to reduce the severity or how often you're going to get a hot flush, for example, but it can really help you in how you perceive that hot flush is bothering you. So if I'm sat here in front of all of you amazing people and I'm suddenly got a hot flush coming on and I'm really hot and I can feel the redness coming up in my face, and all I think about is, oh my gosh, everyone is going to think, look at her face and look how hot she is. And there she talks about menopause and she hasn't got her own hot flush under control. Then it's really going to impact me speaking to you tonight. But if I can expect perhaps that, yes, I might have a few hot flushes today, and yes, it is going to come, but I also know they're going to pass again. I also know that most likely you're there with your notepad and pen, scribbling and taking notes rather than looking at my hot and bothered face. I'm going to perhaps not perceive the severity of the hot flush quite so badly. And so don't dismiss it. CBT, like any other speaking therapy, we have evidence for it that it works. It's a lot of studies done on women who are in menopause after cancer, especially because they might not have access to hormone replacement therapy. And so it's not to be dismissed. We also want to open tools for you like acupuncture, and it is also recognized by the British Menopause Society as a very helpful intervention. And a regular practice of yoga, mindfulness, perhaps counseling is something that you think, oh yeah, I'm thinking counseling is really good for people, but not for me. Explore that thought. Dare I say that most of us, when we hit our 40s, could do with a little bit of counseling, and especially once we've had a cancer diagnosis and we're thrown into menopause. And people have tried hypnotherapy. And so keep your options open and maybe think, this is for some people and this is for other people. What resonates to you today? What would you like to know more of? Are you curious about something? And open the conversation. Bring those things into your life, and perhaps you'll feel a spark and you think, yeah, I'm at my wit's end with this. I'm going to try and see if my GP can refer me for cognitive behavior therapy, or whether I can go on a course. There are many courses online. Helena, how does it work with CBT through your GP?
Yeah, again, so this will be really area dependent, but
Okay.
I know in a lot of areas, including the Manchester area, you can actually self-refer for CBT. What I would say is if you want to discuss low mood, anxiety, other symptoms of menopause, definitely still worth speaking to GP, and they can always signpost you to these services. But depending on the severity of someone's symptoms, for people that have mild to moderate low mood or anxiety, they can very safely self-refer through certain organisations to have psychological therapies. So in the Manchester area, that's a service we call self-help, which you can Google, but in other areas that will differ really depending on what's commissioned in those areas. But yeah, I'd still speak to GP because it's definitely worth getting that support in place, but they can often either refer you or signpost you to self-refer to these services.
Great. I'm going to get to a couple of the questions in a moment. Let's carry on then. Right. When we talk about our lifestyle, often women think, I need to do everything in one go. I need to change my nutrition, the way I eat. I need to start exercising or move differently. And I need to look after my stress management and bring in a lot more self-care. And to me, that already seems like a lot of pressure. And it's also a little bit too much. And dare I say, is if we do too many things all at once, nothing is going to stick, and we're not going to be able to sustain all of those amazing lifestyle changes that I'm sure you've put a lot of hard work in thinking of how to putting it together. So my advice would be to do a little bit, to make 2 or 3% of a change, choose 1 or 2 areas, do that for a few weeks, and then introduce another change. In general, whoever I speak to, and that might be anyone who has never been affected by cancer or menopause, most people think I need to eat a little bit better. If you have thought, How do I improve? How do I change my diet? We've got a few really simple tips. And that is not to follow someone else's meal plan. You're never going to be able to sustain a meal plan for the rest of the month even, let alone for the rest of the year. So how can you start to eat a little bit better? The easiest way is to increase the amount of vegetables and plants you eat every single day. If you're at the moment someone who never eats any fruit, go out, look at all the amazing fruits there are. And if you can afford it, just buy yourself something really lovely and start bringing some lovely fruits into your every single day. Look at root vegetables, legumes, oats, whole grains, good quality olive oils, nuts and seeds, and include a serving of beans or lentils once a day. Most importantly, make a plan. It's really difficult to sustain any dietary changes without having a plan. We want to think what you can add rather than what to remove. So if you're thinking, I must just stop eating all the sugar, I'm eating too many cakes, you're going to just shine light on what you shouldn't have, and it's going to want you have those things even more. So instead, shine light on all these amazing vegetables and whole foods that you can incorporate into your diet, and add a good quality amount of protein at every single one of your meals. So if you're thinking, where do I start? You could think, I'm just going to start by making 3 or 4 really yummy, tasty and healthy breakfasts for myself. I'm not going to tackle lunches and dinners, snacks, none of that. Just start with one area and make a few little changes, sustain them over a few weeks, and then add another change. Otherwise, you're most likely just going to fall off the wagon and then think that you weren't strong enough to sustain and stick with it. Whereas we know you've got to make really little changes for them to be incorporated into your daily routines and lives. With exercise, I personally feel it needs to be prescriptive. Exercise can reduce your risks of a cancer recurrence by up to 30%. I've got an amazing Professor Dr. Anna Campbell who runs all of the studies in Scotland and England for us. And she's done all the research in this field. She's one of the world's leads. I've interviewed her on the podcast. And if you're interested in this, I recommend you to go and listen to this episode. She suggests to aim for about 150 minutes of movement a week. If you're now thinking at home, but how exactly should I move to get that benefit? What do I need to do? Then again, this isn't how we need to think, because we're all so different. If you're just recovering from surgery, your levels of exercise will be different, but anything and something is better than nothing. Start by walking, walk a little bit faster, maybe do 5 squats whilst you brush your teeth. Why don't you just do some calf leg lifts whilst your kettle boils? It doesn't need to be much, but if we can all move a little bit more tomorrow than we've moved today, then that's a really, really good starting point. It doesn't need to be an expensive gym membership. It can just be getting out there and getting that walking done every single day if your energy levels allow you to do. We know, and we have got loads of evidence to support this, regular exercise helps with cancer-related fatigue, sleep, weight loss, and also joint pain. And so exercise, to me, is madness that we don't get it prescribed when we recover from cancer and when we want to address menopausal symptoms. Stress management and self-care, we've said that before in the previous slide, like meditation, mindfulness, important to look at.
The other thing is just worth mentioning there, Dani, I know you said it's not prescribed, but actually what some GP services do have, again, I'm sorry to say this again, but it does vary depending on what region you're in. They do have schemes called social prescribing. So it's really worth asking whether that's available in your area. So that's where we can signpost you to kind of health practitioners and workers who can essentially try and put you in touch with kind of organisations or groups that can help you achieve your aims in terms of doing more exercise or help with diet and nutrition. So it is worth noticing that in some areas you do have those services available, and they're often we don't hear about them, we don't know about them.
That's absolutely brilliant, because we feel so active when we can maybe have the extra portion of vegetables a day. When you start to move a little bit more than you moved last week, it makes us feel so empowered that we're on a road to recovery and healing, and that we're actively doing something every single day. And that can be so positive and beneficial to us that it really, really brings so many more benefits into our life. So have a little rethink of how you can map out that plan
Absolutely.
for you. I do want to notice triggers, because triggers can be really easily dismissed, and they can be really quite powerful. So, for example, when I was drinking a hot cup of tea earlier, but for those of us who love herbal teas in the evening, for example, but you then struggle with hot flushes or night sweats, it's a hot bath in the evening, cups of tea in the afternoon and evening can actually contribute to you having a worse experience of a hot flush at night. It's just how our circadian rhythm works and how our body stores the heat and then pumps it out later. So start to notice who you are and what your triggers are. Alcohol, we know, red wine for some women, gin and tonics for others, can really increase the severity of our hot flushes and negatively impact the quality of your sleep. And have a little notice of why you drink. Many women who struggle with anxiety might have that glass of wine or two in the evening because they think it takes the edge off, but actually it makes your symptoms worse the next day. Caffeine is the same. Sometimes heart palpitations can be triggered, be made worse. Caffeine doesn't affect other people in the same way as it affects me, for example. So just becoming more aware of who you have become. This post-cancer, post-menopausal woman, how is she? How does she need feeding? How does she need to move? And what affects you, and what triggers could you sort of work with? Stuffy bedrooms, for example, stressful situations. How can we prepare for them? All can really contribute. And I always say we need to get to know the new version, the new me, and part of becoming more knowledgeable about who you are and how you tick now is to sort of become aware of your triggers. So don't underestimate how important they can be. We know it's a lot. I call it the cancer hangover. When your body is under mental or physical stress, it will produce more of our fight or flight hormone cortisol. And sometimes that can go on for much, much longer than you anticipate, with or without a menopause. Sometimes we feel we should be back to who we were before our diagnosis within a few months, within a year, and then reality sort of hits us and life is still very different. We know also that the stress hormone cortisol can cause palpitations, sleep disturbance, lack of energy, weight gain. And over a period of time, it can even have a negative impact on our bones. Chronic stress in combination with lower hormone levels can make all of our symptoms a lot worse. And so it's really worth considering how you need to look, how you can look after your stress responses and your stress home. And have you spoken to anyone about perhaps your anxiety or your stress levels? Is it time to speak to anyone whether counseling would be a good idea for you or not? And it's just one of those things that we think, oh, I'm just stressed. I've been through a lot. I'm just stressed. But we know this is so tough for so many of us, and surviving cancer is really tough on its own. Add menopause, it is really a lot to deal with. And so that stress alone needs to be dealt with as much as your other menopausal symptoms. And although I'm nearly 10 years on from my own diagnosis, I'm still working at it. It's nothing that can get fixed. It's definitely work in progress. I wonder at this point always how you're feeling. What have we forgotten to mention that you really have lots of questions for? Helena, do you think we should, do you want to take a few questions now
I've seen a couple.
So
a couple of you mentioned about melatonin. That's a treatment we use for sleep. It's usually, well, it's licensed to be used short term. And the reason I didn't go into much detail about it, because again, I hate to say this again, but it's regional variation. So in some areas, I think it does have to be actually prescribed by a specialist, at least initiated by a specialist. So that's why I didn't go into too much detail about it. It's not necessarily part of the menopause toolkit in terms of the BMS menopause toolkit, but it's something that some practitioners do use for sleep. But as I said, in some areas, it has to be specialist initiated. So it's not necessarily something your GP will have immediately to hand, if I'm perfectly honest with you. So there's some good evidence for high dose glucosamine for joint stiffness that's linked to wear and tear in the joint, or a condition we call osteoarthritis. So there is some evidence for that.
And the other thing to add to that, yoga stretches, and you could just do a YouTube class that is free for you, 10 minutes. because sometimes when joints are really stiff, we want to avoid to move them, but actually that lubrication in our joints and in the sockets is really good. So some gentle yoga and some breathing can really aid on top of your supplements. It's a really good way. And you still might be not feeling great. So please do celebrate all the wins, because unless you celebrate what you're doing right and what benefits you, it's really hard to sustain it. So well done for all of you anyway.
The other thing I just want to make really clear, and apologies if I didn't do this earlier, is that you don't actually have to go to GP seeking a treatment, is the other thing I just want to make really clear. You can just go to talk about what you're experiencing and how you're feeling, and have that just have a conversation with someone for support, really, because that's, as GPs, we're there to support you as well. We're not there just to prescribe something for you. So I just want to make that really clear, because I know some of them might feel they're in quite a lonely place. If you are suffering with either menopausal symptoms or issues with your mental health, it's definitely worth booking that appointment and having a chat with someone.
Absolutely. If anything we can give you a way tonight is to make that call and reach out to someone and see where it takes you. Helen, I just want to address this. I was told to avoid plant-based phytoestrogens. That's incorrect advice. Again, I've interviewed one of the lead dietitians who works with a big cancer hospital and who's a menopause specialist on the podcast again. And she really, really explains the evidence and the facts behind phytoestrogens. And even for women with breast cancer, there's no reason to avoid phytoestrogens. It's a big myth circling around out there, but I can point you to the right evidence, and if you want to. The evidence for turmeric, in my view, is if it really tastes really lovely in a curry, use it with some black pepper for some great absorption. But apart from that, I don't think it's recommended as a menopausal treatment. Is that right, Helena?
I don't think it's on the formula. I'd have to triple check that for you.
Yes.
I think it's one of our top known.
Yeah. Yes. But I make a really lovely golden milk. So I sometimes use coconut milk or any other milk. And I warm it up for myself, and I put some turmeric in, I put some cinnamon in and a bit of honey, and I whisk it up so it froths up a little bit, and I call it my golden milk, and I love it in the evening when I snuggle up in bed with a book. So maybe that's a nice way of having turmeric. Right. What you can do today and what you can do over the next few days is, like Helena just said, do contact your GP and do reach out for that next conversation. And if you think, I've been to my GP and I've not had any help, ask your GP to be referred to a menopause specialist. But one thing that is brilliant before you do either of those steps is track your symptoms. For those of you who like to do it on a phone, the Balance app is a free tool. You can find it on the App Store and you can track your symptoms. And you can then take that to your GP or menopause specialist and say, look, I've got all of this going on. Those are my top 3. Someone help me do something about it.
If you don't have a smartphone, but you do have the internet, there's also a site called Rock My Menopause, which has a symptom checker, which you can just download as a document. So you can always bring that as well if you don't have a smartphone.
Yeah. Or you might just take your phone out or a piece of paper and you just write it on a
symptoms,
piece of, write your symptoms down, what you think.
Yes, absolutely. You don't necessarily have to check it. They're just a good way of visualizing it for yourself, if you want just to, because some of the symptoms, like as I mentioned before, people don't realize are even to do with menopause. So that's why these are quite useful tools. But again, they're not a necessity.
Yeah. Yeah. And then do speak specialist care, follow all the advice of how your GP can liaise with your menopause specialist. And if you decide to go onto the British Menopause Society website and you put in find a menopause specialist, you have a little tab on the right-hand side that is either private or NHS. Click the NHS option and you can be referred outside your borough. So if you live in Wales, you can go and see a menopause specialist in London. You don't need to have someone that is attached to maybe where you were treated, your local area or your hospital. I don't think everyone knows that. And so do your research and get on that list. If I'm going to say so myself, but I have had the most amazing guests on the Menopause and Cancer podcast. And I really try and find guests and experts that have either done the research themselves, like the Dr. Philippa Campbell, the professor who's done all the research about the benefits of exercise after cancer in menopause, or all the amazing dietitians. these experts really, really know their stuff, and they're real experts in their fields, and I love interviewing them. And before I do so, I go in my private Facebook community and I ask all of my hundreds of women in there what questions they would ask the specialist. So mainly it's not even my ideas of what I would ask, it's a collective question and answer session. And so if you have specific answers, you can tune into that. And we know we're 20 minutes late, but we want to say thank you. And if you look on that slide there, all of these amazing people run the Peaches Womb Cancer Trust. You're all experts, aren't you, Helena? And it is amazing that you pulled this off. You've created this amazing charity, and that we're here today talking about menopause. I mean, that really, obviously, I'm very happy that we talk menopause, but you do so many other amazing things.
Yeah, absolutely. So I think a lot of people here will know us, but if not, we are dedicated womb cancer charity within the UK, and we do provide some support services which include our coffee mornings, and also there's lots of information within our website, so please do visit us, and we're also on social media as well.
We know, Kat and everyone else, that we've only given you a starting point, and we know this is perhaps going to spark an idea for some of you, and some of you might walk away and put nothing into practice, but maybe a few months down the line you think, oh, I remember what Helena said, I think I'm ready to make that call to my GP. There is no timeline, is there, Helena? And
no, and I think, I hope what we've really reiterated this session is that you know, that you feel kind of seen and heard with your symptoms, really, and the concerns that you have. You don't have to do anything. You don't have to go and get medication prescribed. But if you want that information, you want that discussion with your GP, do advocate for yourself and do make that appointment. And you know, hopefully we've signposted you some really useful resources.
Yeah. And if one thing you walk away from today, then you know how many other amazing people are in a really similar situation, and you're most certainly not alone. And that is something we really also wanted to make sure we remember from tonight's conversation. Lovely to spend the evening with you, Helena.
And you. Thank you, Dani.